Okay, I'd like to call this workshop to order. I know everybody was having a good time and my colleague Mary Jo was entertaining everybody in the back.
Yeah, I'm gonna tell you why in about a second here.
I wanna thank you, the Regents folks, for coming to have a chat with us here at the Ramsey County. This is a workshop where we sort of discuss issues, begin the process of developing different policies and so forth. I'd like to introduce Emily Bloomberg, who I just met very recently last November or so. She's the new president of Regents Hospital. And she's worked around the country, but part of her resume is working, what were you at Hennepin County Chief Operating Officer?
Yep.
Of Hennepin Medical, right?
Mm-hmm.
And so I just said to Emily, you know, she's new, at least to Regents, and we have a new board, a new county manager, and it'd be a good time to sort of get to know each other. We have a lot of common issues, and maybe we could find new ways to work together in partnership. So I will begin the process of going around the room, which is what we basically tend to do here, and to the audience, so people could introduce themselves. I'm Rafael Ortega, Ramsey County Commissioner for the 5th District. Go ahead.
Ramsey County Commissioner Mai Chong-Shan. I represent District 6, or most of the east side of St. Paul. Ramsey County Commissioner Tara Jevon Singh. I represent District 1, which is the northern suburbs.
I'm Brett Hockey. I'm a neurologist by training. I'm the Chief Medical Officer at Regents, and I've lived on and off in Ramsey County since I was 2 years old.
I'm Emily Blomberg. Thank you for the introduction before, President at Regents Hospital.
John Clark, VP of Finance at Regents Hospital, been with Regents for 16 years.
Hi, Rochelle Johnson. I'm the Chief Nursing Officer and Vice President of Patient Care at Regents Hospital. Also, my first home was owned on the east side of St. Paul, so proud St. Paul.
Good afternoon, everybody. I'm Pahua Hoffman. I lead the Government Community Relations for Health Partners. So I have worked with some former legislators here in the room. Familiar.
Lingbecker, County Manager. Hello, everyone. I'm Mary Jo McGuire, County Commissioner for District 2, which is between the city of St. Paul and the outer suburbs. So I'm in the middle suburbs of Roseville and New Brighton, Middle Canada. And I carried the legislation when I was a legislator to merge regions to create regions, actually. Ramsey County or Health Partners took over Ramsey County Hospital. And Jan Malcolm is a name that we all know. She was part of that deal. So she worked for Health Partners at the time, and just was proud to be chairing the delegation at the time when the Ramsey County asked me to do that. So we have a long history with this issue, with all of you.
Good afternoon and welcome. My name is Rena Moran, District 4. So I represent Hamlin, Midway, Union Park, Frogtown, Summit, North End, some of downtown, McAllister, Groveland, and a little part of Highland Park. And I do believe Regent is my district.
Bonjour, everyone. Kelly Miller, Commissioner for District 7. I represent Maplewood, North St. Paul, and White Bear Lake.
Okay, again, Chief Clark, County Manager's Office. Hey, James McLean, Director of Government Relations for Health Partners and Regents.
Hello, Jennifer, we're Director of Government Relations here at the county. Karen Francois, Deputy County Manager for the Information and Public Relations Service Team. Amy Karen St. Paul, Ramsey County Public Health Director. Diane Holmgren, Deputy Director of Public Health. Sophia Thompson, Social Project Director. Zinogala, Medical Director for St. Paul Ramsey County Public Health.
James Zachary, Senior Policy Analyst and Policy Planning. Larry Timmerman, Policy Planning.
Prince Bernard, Senior Policy Analyst with Policy Management. Hi, Gloria Reyes, Deputy County Manager for the Hi, Maria Galia, I serve as the Chief of Staff for County Manager. Hi, Alex Pizza, Interim Deputy County Manager for Health.
Thank you all. And John, were you gonna read the, Emily?
I think the next slide, Commissioner Ortega, I'm just gonna go over, since we've already done welcomes and you see our names now to our faces here. I thought I would just outline our goals and our agenda today, and then I'll pass it on to Emily to give some Regions updates. So thank you again for having all of us from Region and Health Partners be with you today for this workshop. Our goals are to learn about, for you to learn about the hospital and the relationships we have with the county. To present to you and have a discussion around our challenges and opportunities and highlight areas where there could be a deeper partnership and areas for improvement on both sides, and then discuss and explore some of those solutions together. So our agenda on the next slide is we're going to give you a hospital, Regions Hospital overview. And I'll come back and talk to you a little bit about our community engagement partnership work. And then we'll cover the Regions Ramsey County lease agreement and talk about our patient care and then the challenges that not only Regions is facing, but I would say all health systems are facing in the state and in the country. And then, of course, we'll make sure that there's time for Q&A.
Okay, I thought I would start by just talking a little bit about who we are, Regions, both from a size and scope perspective, but also more importantly, our mission, vision, and values. So you can read through those, but I think that at the core of our mission is to support this community and serve all of the patients that come through our doors, regardless of their ability to pay or their background or any other considerations. And we pride ourselves on that. We have a very strong culture as an organization. That's one of the things, I've been with the organization for 8 months, so relatively new. And like Commissioner Ortega said, I've been at quite a few places, and this is one of the best cultures and most mission-driven organizations that I've ever been at. Our values are really real. We try to hire to those values and work with our staff to maintain those values, and they're very important to us. So I would say just calling that out as a really important part of our mission. Are we driving?
Yeah, we're good.
Okay, so by size and scope, I'm sure everybody is familiar with Regions and has seen Regions. It's a large place, busy trauma center. We have 546 available beds. We have been very, very full in all of those beds as of late. A little under 30,000 admissions a year, 167,000 patient days. These are 2023 numbers, and I'm specifically calling that out because we have had a milestone of reaching 100,000 ED visits, which we did this in 2024 in late December. So I'm going to share a little story about that, and then have been really busy in our labor and delivery space as well. So we are growing. We have been busy. We continue to grow. These numbers year over year have continued to increase. So if you want to flip to the next slide.
ED emergency.
Emergency department. Yep,
Thank
sorry.
you.
Call me out if, we're big on acronyms in healthcare. So call us out if we get stuck there.
That goes both ways.
Yeah.
You're learning that front and center. So we have been anticipating that we would exceed 100,000 visits in our emergency department, and that's a lot. That is very busy. And so had been sort of planning for this 100,000th patient, and that we would kind of have a little internal celebration. And it just happened to be this man, Dan, who has given his permission for us to share his story. And he happens to be a retired deputy from the Ramsey County Sheriff's Department, who lives a couple hours up north, but was here visiting one of his newest grandbabies and became sick and wanted to go to Regions. He's had some previous healthcare needs and has come to Regions. So he came and just happened to be our 100,000th patient. He also worked in, we have an off-duty officer that works in our emergency department, and he did that for 16 years. So it was kind of serendipitous, and they had a little celebration, and it was just really great. But point being, we provide really great care. Our emergency department is busy almost all of the time. It is particularly busy today and these past couple of weeks with all of the sicknesses and viruses going around. And so this is just a quick story that we wanted to share. We get a lot of awards.
varying in all areas of the hospital, both from accreditation perspective and just things that we do well. I just picked a couple to share with you. One of them is from Practice Green Health. And this is their highest hospital award in the sustainability area that we have achieved, which we're really excited about. We're really focused on sustainability and how we can do things better and more efficiently and reduce our carbon footprint. And the second is for our stroke care from the American Hospital Association. And this is just an award that we get for meeting, there's a core standards that they have and we achieve excellence in those standards. And so have gotten this award for that, but I would also say that we recently had we are a comprehensive stroke center and we had a recertification visit. And I would say Brett and I were at the report out and they had wonderful things to say about Regions. And just to kind of quote one of those items, the folks that do this survey spend their year going to different hospitals around the country doing this survey. And accrediting hospital stroke programs. And she said we had one of the best standards of care she's ever seen for stroke care. So we are very proud of that. And then lastly, everyone probably is aware of this, but we are a part of Health Partners as a broader organization. And we that is a really important part of who we are. And I think it also allows us to really focus on wellness for our members in partnership with our care delivery system. And we are a really large organization, but from my perspective, and one thing that I've learned since I've joined is we are a really large organization that feels like a strong family. And all of the care delivery in the care system, all of the care delivery are really focused on quality. And that is really important to me and our team. And I think that the health plan side helps us to focus as well on well-being and bringing those two pieces together.
I'm back. So I'm going to talk about the work that we do internally and also the culture at Health Partners. So soon you'll hear about our patient care directly from Dr. Hockey and Rochelle Johnson. The fun work that I get to do at Health Partners is partner with individuals within the organization and also individuals, community members and organizations outside of Health Partners facilities. I think all of us know, especially those who work in health or healthcare adjacent, we know that while we strive to provide the best care within our facilities and our clinics and hospitals, we know that people are most impacted in terms of health and well-being outside of those systems, right? 80% are impacted by social drivers of health. And that's why it's important that we make sure that the folks who work within Health Partners, either at the hospital, in clinics, or at headquarters in Bloomington, all are finding ways to support each other in this work. And so what you see in front of you are our cornerstone image of how we embrace diversity, equity, inclusion at Health Partners. And you can see the 4 cornerstone there, increasing diversity and inclusion in our workplace. So how can we build a strong pipeline of people who want to not only work for Health Partners, but work in healthcare in general? There's the advancing health equity in our care and coverage, and thinking of ways to specifically strengthen our commitment to St. Paul. This cornerstone is actually phasing out, not because it's not important, but because over the course of learning over 3 years, we're going to embed those learnings within the other cornerstone. And the last cornerstone, the partnering with community advocating for change cornerstone, is the one I get to chair. And I'm going to talk a little bit more about in the next few slides about the work that's under that cornerstone. And then all of us make up what's called the Equity, Inclusion, and Anti-Racism Cabinet that's chaired by our 2 physicians and also Andrew Lawson, our CEO. Next slide. So again, healthy and high-performing teams is a phrase we use a lot within Health Partners, that we can only deliver the best care and be the best partners or be the partner of choice if our culture is healthy. And so we want to make sure that our teams have what they need to succeed. And here are the ways that we have showed up for each other. These are just some pages within our internal website about how do we share the good work that we're doing across our 28,000 employees. So just take a moment here to just let you take in some of the highlights here on this slide. And I can answer any questions you may have later. On the next slide, I'm gonna turn now from internal to how do we work with our partners in the community. These are just 6 dimensions of ways that we partner outside of our organization. Obviously, these are complementary to our care delivery services and our health plan products. But these are 6 dimensions that have come through on our community health needs assessment as priority areas. And on the next slide, you could see that under the cornerstone, that partnering with the community cornerstone that I chair, here are all the partners who we've had in the last year. So this is looking back at 2024, just some highlights for you. I want to call out Commissioner Helen Miller, because when she was at Interfaith Action, they invited us to be a key partner in their economic mobility hub. And so that is a highlight that we want to make sure we share. We also, for those who might not be aware, Health Partners was a founding member of Super Shelf, and we continue to develop and make sure that food shelves are certified, provide a dignified space where people can get culturally appropriate, healthy food in a respectful environment. And I mentioned a little bit about our community health needs assessment. We're at the tail end of that work now, and we're in the process of putting together implementation plans, which will sit on the region's hospital website. And then some of you may be familiar with our community health program, such as Make It Okay. It's been around now for 10 years. This is our I would say our tentpole initiative to eliminate stigma around mental health. And then we also have early childhood work that we call Little Moments Count. In fact, in December, we just held our annual conference, and we were lucky enough to have Lieutenant Governor Flanagan come and be our speaker. And then on the community and colleague engagement, you could see that volunteerism is something really important at Health Partners, and we want to make sure that our employees also are participating in different ways out in the community. So you can see we participate in habitat builds, we participate in the NAMI walk. Maybe I'll stop there.
I'm just gonna give you a brief kind of review of the lease, and I know it's not brief because it actually, the arrangement between Regions and the county has existed for 153 years. And so just give you a background from 1927 to 1993. Most of these discussions and legislative agreements were done both with the county and a hospital board. It was a combined board. And then in 1993, when Health Partners affiliated with Ramsey Medical Center, then it became more of a lease relationship. And that lease relationship said that Regions Hospital would take over the space, and the county would allow them to use that land and space. But then in return, Regions needed to provide what? They need to provide indigent level care is the term. I will say charity care is how we commonly report it now. Last year, we provided over $20 million of charity care for over 31,000 patients. That means we wrote off their entire bill or part of their bill based on their financial need. In addition into that lease agreement, we also agree to improve the space and the space around that location. So just to give you some history, 2008 and 2009, we added 11th floor building that doubled the size of our emergency room, and we continue to expand our emergency room, and partly why we're at 100,000 visits this year as well. In 2012, we completely replaced our mental health building and replaced those at the time 96 beds to 100 beds. And we moved from what was a horribly set up 2 bathrooms for 20 patients to completely private rooms is what we now provide. Know that in that space of 100 acute mental health beds, 70% of those patients are on medical assistance. And then in 2020, with leadership with Rochelle and team, we also opened a new birth center as well. And I know there was incredible partnership with the community on engaging all cultures and religions and in the manner in which you wanted to have your birth. So it was an incredible work effort with the county and the community at that time too. So that's part of the agreement, is continue providing care for the indigent. And I will also say that in addition We are the caretaker for Ramsey County prisoners as well. We also have 2 jail cells in Regents Hospital if needed. And so patient care has a unique relationship with our Ramsey County sheriffs as well. When they bring a patient in, there's always an arrangement on who's going to provide the care. And there is also a deputy sheriff with that patient.
So I'll build off that.
Okay.
So Rochelle Johnson, reminder again, I proudly represent our patient care teams. So those being all of in partnership with Dr. Hockey, every person that would touch you in the care that you get at our hospital, we get the pleasure of leading those teams. And we could tell you about a million different ways that we do that really well. I could tell you about our ICUs that have a beacon gold banner that is 2 of our ICUs out of 164 in the country live at regions that have that designation, which is very rare and hard to get. I could talk to you about our inpatient rehab facility that is nationally known and sits at the top of the list for quality outcomes for patients who need extended rehab services. Could talk to you a little bit about our award-winning burn center, which in our regions is set apart in our country. They actually just our leaders in our burn department just wrote the certification exam for nurses as an offering to the country. And so we have a lot of services that we could brag about. We're going to brag about a few of them and would be happy to answer any questions that y'all have. We talked a little bit, Emily did a really great job of sharing a little bit about our emergency department, and we probably could spend a whole hour talking about the care that's provided in that trauma in our level 1 trauma center based in the emergency department. But if you go to the next slide, I'm going to share with you something that sits really close to my heart. And I worked with some people in this room on this program. And so I'm entering my 2nd year as the CNO of the hospital. Prior to that, I had the honor of leading the development of this new birth center. It started back in 2017 with the recognition that our investment in a new birth center was actually going to pay us back in our community in multiple ways. And so caring for those newest patients in our community and making sure that they started out in a healthy way and their families got the care that they needed immediately was going to pay us back and make Regents be the hospital home for many patients in our community. So some of you may or may not know this, but 60% of the patients that deliver at Regents Hospital are patients of color in our community. 25% of those patients need an interpreter for their care. 50% of those patients use some type of government help for insurance to have their families. And so we started with that. And when we designed this building, we said, we can't do it alone. Our hospital has to be really interconnected with the community programs to make sure that whatever we develop in this building is actually for the people who are going to visit it and use the services. So it's a beautiful building. One day I hope you all can come there and see it, but from the principles that we put in place from a high reliability perspective, giving the highest quality care, to making sure that every policy that we have in the building is family centered, to centering healthcare equity in the middle of everything that we design. This building was made special, and it's actually those principles are flowing into the way that we lead and the rest of the hospital. We're really excited that we almost hit 3,000 deliveries, too short in 2024. So we've increased by about 15%. So many of you know that people have a choice of where they want to deliver their children. And so we've increased our volumes of patients that we're delivering by 20%, which means the community is seeing the care that we're giving. They see the quality care that they give, and then they choose to come to us even more. And so we're really proud of this program. One of the most important things that we did in this program was the recognition, again, that 60% of our patients are people of color. 35% of our patients are actually come from identify as African American. And in the African American community, some of you may know that disparities and outcomes for families don't match, our white partners or our white counterparts in delivering. Things like postpartum hemorrhage, hypertension, those are diagnoses that kill Black women 4 times more than other women. And our American Indian families experience that too. And so we take that really seriously. A lot of the leaders that you see are a lot of physicians in this picture. They actually lead a lot of programs within our community. So the maternal mortality review committee is led by one of the doctors in this picture. The Minnesota Perinatal Quality Collaborative is led by a Health Partners physician. The MHA Perinatal Committee is led by a Health Partners physician. This is really important because they carry those values of caring for all of our patients, making sure that we center those healthcare equity principles and practices in other spaces outside of Health Partners. So we are leading the way in making sure that we can decrease the disparities that we see in that care. I'll give you the statistic that we decreased the incidences of postpartum hemorrhage by 18% for African American women last year. And that gives me goosebumps because that's women's lives saved. So that is, if you take one statistic with you, share that one with people. So really proud of this program and happy to answer any questions that you have on that. Go to the next slide. Another program that we could brag about for probably an hour is our mental health program. And I think many of you have heard of the mental health services that we have, the Make It Okay programs, the programs that we do in the community. We have 120 beds in this mental health program at Regions Hospital. That is the most inpatient mental health beds in the East Metro. And so this team works really hard to accommodate the needs of our community from a mental health perspective. We were one of the only hospitals during COVID to actually extend and expand our beds to make sure that the community had what they needed. So we opened a whole unit during COVID, and that's Sarah Cassell. Some of you may know Sarah and have worked with Sarah. She is a strong mental health advocate and serves on a lot of committees around mental health, but that's her cutting the ribbon during COVID on our 6th inpatient adult mental health unit. So this team has won a lot of awards. We have a partial hospitalization program too that's led under the structure, which means we do a lot of work to make sure that patients can be home. Being in the hospital is not the best place for any patient. Providing intensive mental health services in a way where people can come during the day, get those intensive therapies and still be at home with their families is really important. And we have a very strong program. It's called Daybreak, and some of you may know about that program. We also recently this year opened what we call a long-acting injectables clinic. And this is a unique clinic. Sometimes patients have to stay in the hospital because they require medications that can only be given by an injection. And so those injections can only be given and you have to be monitored for those injections. So we used to keep people in the hospital for those injections. Now we are able to send those patients home making it available, a clinic space available for them to come back, receive their injections, be monitored, and then go home and be with their families again. It helps stabilize their mental illness that they're experiencing, but also helps with their continuous therapy of being in their home setting. So we're really proud of a lot of these programs. I could go on. And Dr. Hockey is going to do that for me. I'm going to pass it over to my partner.
Thank you, Rochelle, and thank you all for having us here. And I'm so thrilled to see the rest of the community servants here to help hear our presentation. I think probably many of you have experienced Regions. I don't know how many of you have walked the halls very much, but it is an extremely special place. It is a very mission-driven organization, and we've been here to serve the community 24/7 for 150 some years. And you can talk to any policeman, you can talk to any fire person, you can talk to anybody who knows where they can take their sickest patients, and they will say that Regions is the place that consistently takes care of patients. And that isn't coincidence, and it isn't something that happens easily. There's just a certain subset of care providers that are willing to step up to the plate and do 24/7 care. And when you're a level 1 trauma center, you have to be available every hour of the day, every minute of the day, and it attracts people that are willing to do that. The other side of that would be working in a clinic from 9 to 5, doing colonoscopies in a private clinic. And and so it's a very differently wired organization. Some of that during COVID, patients were coming to the hospital and they were very hard to make healthy and get discharged out of the hospitals. And every single hospital in the state of Minnesota contracted and actually took care of less patients. Regions increased the number of patients they took care of by 100 patients in the last 10 years. And it isn't because we had a growth strategy. It's because we don't think we can say no to patients that show up at our door. So it's a very, very different mindset. We've done a lot of firsts. The first level 1 trauma center, in fact, there's some data to suggest we're the 7th busiest trauma center in the United States today. We were the first to do burn center. We were the first to do comprehensive stroke. We were the first to do the biggest freestanding psych center, freestanding neurosciences center. And again, I would argue it's because of our mission and our values to give good experience, give good quality, and actually create more affordable health that has helped us to be able to do that growth. So I'm going to tell you just a little bit about the ECMO program as an example of that. ECMO stands for something worse than ECMO. So, but it's extracorporeal membrane oxygenation. You're going to prefer just calling it ECMO. But this is a program where, think about if somebody, their lungs stop working or their heart stops working. So literally they show up in a hospital dead for all practical purposes. We can put them on a machine where we put take their blood out, oxygenate it in a machine and bring it back into the body. And we can bypass the heart that no longer works, or we can bypass the lungs that no longer work. And we started that program at Regions in April 2024. Since that time, we've done 27 patients, which already puts us into the category of high volume program. 80% of the people have walked out of the hospital, which puts us into the 90+ percentile of ECMO hospitals for survivability. And that's in our first year of having to train hundreds of people from 10 different specialties and all the different nursing staff to support this program. Now, a few other words as to why we did this. During COVID, 90% of the patients that could have survived had they gotten ECMO were not able to get ECMO anywhere in the country, in the state, in the region. If those patients had gotten put on ECMO, 50% of them would have survived. And we just were like, that can't happen to us again. The second thing that happened was some leading edge research out of the University of Minnesota that helped us understand that if somebody falls out in the community with an arrest, so think about the person at the gym who just falls out, and it almost always happens during a sporting event. So, but if someone grabs a paddle off of the wall and they start resuscitations and give somebody a shock, which most gyms have on the wall, about 4% of the people spontaneously get their heartbeat back and they survive. Out of the other 96%, 5% of them survive. If we can have an ambulance get there, start them on ECMO in the first 30 minutes, 80% of them survive. And so we have become the center. Turn to the next slide. We've become the center on the east side that resuscitates people that have arrested in the community. And we start the ECMO in our ER, and we've done that 180 times since the inception of the program in 2019. These little gaps in the graph, each one of these bullets is a human being. And these gaps are during COVID when we just were overwhelmed with patients and struggled with being able to keep our ECVR program running. And since we've started ECMO, we've had just some amazing stories, and I'm going to tell you about one of the stories, but it was a gentleman who had a neck surgery at a different institution, was in a transitional care unit, getting his health back. He developed a large blood clot, and the blood clot got stuck in his lungs. And the heart has to push blood through the lungs, and the heart couldn't push any blood through the lungs because the blood clot was so large that the heart immediately stopped. We started ECMO in our emergency room. We sent the person to a cath lab, a lab where they put a catheter into the lungs. We pulled out all of the blood clot so the blood could reestablish its flow, and that patient survived. And had he not come to an ECMO competent program, he would not have survived. I'm going to show you a letter that the daughter sent us. And I'm going to read it here because I think I'll have a better chance. To the beautiful humans who saved my dad, there are not enough thank yous in the world to share my gratitude for what you did. You made a miracle happen. During the scariest time in my family's lives, we felt better knowing you were all giving him the best care. You treated him with kindness and dignity, even under heavy sedation. You worked tirelessly and around the clock to make sure he was stable. The work you do, not only for my dad, but for every patient that comes into your care, is extremely admirable. You're nothing short of angels sent from heaven. I'm going to get married in 5 months, and a week ago I saw flashes of my big day without my biggest supporter. Because of you, my dad has the chance to walk me down the aisle, dance with me, and see my future unfold. I'll never stop thanking you for this from the bottom of my heart. Thank you. And this represents the kind of work we do each day. And I tell the story for a few reasons. One is how compelling it is. Secondly, it exemplifies how we step up to the plate. But thirdly, one of our asks today is to have you think about how we can create capacity to take care of more patients. So we've had 40 patients, 30 to 40 patients boarding in our ER and hallways for the last couple of weeks because we can't get patients upstairs. And the reason we can't get patients upstairs is because we have patients upstairs that we can't discharge. So on any given day, 20% of our patients no longer have a medical need that requires hospitalization. And in many cases, and I will tell you one case example here in a second, we depend on our county partners to help us discharge patients, and things like MA pending and helping people with finances and things like that. And maybe since I started the story, I'll just say that on any given day, we have 3 to 5 patients that are 100% ready for discharge with someone willing to accept them. And we wait 60 to 90 days with them in a bed. So each of those patients take up a bed for 25 other patients that could have a bed. Because an average patient stays 5 days, so you can divide 90 days by 5, so it's not quite 25. But some 15 to 20 patients more could go in for each of those MA pending patients that we could get out of the hospital. Next slide. I want to talk for a second about value-based care. We increasingly, hospitals aren't paid on each thing they do. They get a set fee for a whole hospitalization. And so if a patient stays extra days, those beds just cost the community money. There's for every day in the hospital that a patient stays that they don't need to stay in the hospital, it costs somebody $1,500. And so for every patient that's in a hospital for $1,500 a day, one patient extra for 365 days, that's 4.5 more nurses that a person could hire. And on any given day, we have almost 100 patients in the hospital that don't require any more acute care hospital care. So we are in the midst of being paid for value-based care, which is a high quality care, shorter stays in the hospital, less readmissions, not admitting patients that don't need to be admitted. Next slide.
Excuse me, Brad.
Yeah.
I have a question from Commissioner Moran.
Just on that point, so you're saying that you're not, or you don't release patients back out into the community because they have no place to go?
Correct. We hold patients until we have a safe discharge. And as safe as we can make it, recognizing that there aren't perfect discharges for some individuals. But every day we have patients in the hospital that don't have acute care medical needs that we don't feel like we've matched them up with an adequate discharge.
Is that normal? Do most hospitals do that? Or do
Yeah,
they-
to
do
some
they go that
degree.
extra space and say, well, they don't have a home to go to or someone to care for them, so we're just gonna hold the bed.
I think that all hospitals are faced with the same dilemma. All hospitals, particularly since COVID, have this dilemma. I think that we work as hard or harder than anybody to try to make sure people have a safe discharge, but it does affect all hospitals.
Commissioner Moran, I'll just build on that. So Brett was giving a really good example. So a patient who has a medical assistance application pending, generally won't be accepted at like a long-term care facility or a transitional care facility unless their MA is actually approved. And so those types of patients who need additional care, not to go back to their home, but because they need additional nursing care that is not needed at our level 1 trauma center. We can't send them to those long-term care facilities because they're still waiting on the MA pending. And that's, I think, the connection that Dr. Hockey is making really well.
Thank you for that. We'll show you. Spot on.
I'll just add one more, because I know it's 5 below this morning, and we've had homeless patients that have had frostbite, and to us, it's frostbite or burn, it's the same thing, it's treated the same way. And if they have no place to go to, the rest of us can go to our homes and recover at home. And we could discharge them saying, you no longer need acute level of care, but because they have no place to go to, often we are keeping them for another week and recovering in our facility, or we partnered with other facilities like Higher Ground to take them in respite care. And so those are the situations where in an acute setting, the medical care that we provide is no longer needed. So, but there's no safe place to discharge that patient to recover.
Which is a loss to the hospital.
Yeah.
And that's a loss to the hospital every day.
The other thing I'll say, and I mean, I think it's worth saying this out loud. In a not-for-profit hospital like Regions, we run on extremely narrow margin. We're trying to make 1.5% profit a year. And that 1.5%, 100% goes into building new facilities and updating equipment and things that we need to do to run the hospital. Nobody that isn't going anywhere else except for back into the community care. And every year in the current cycle of revenue decreasing and costs increasing, we have to find another $10 million to cut costs. And in this math of being able to not take care of patients that don't need health care, if we could have the community help us with that, we would be able to get back into the 1.5%, 2% range, and the whole community could benefit from that.
Oh, I'm sorry.
I was just gonna add on your point, it's a loss to the hospital, but also back to your rough math, it's 15 more people that we can't
Right.
move through the system that are either sitting in the emergency department or in another level of care that's not the right place.
Lynn?
Yeah, I was just gonna put a pin in, I know we're gonna talk more about partnerships and opportunities in the future, but that situation around the medical assistance is something that, we should really have a deeper conversation about. I mean, I think, in my first 120 some days here as county manager, I mean, seeing the level of ripple effects from our county responsible services at that, where we are checking eligibility in that backlog, and things have changed during the pandemic. So there are some things we can control, some things we cannot, but we need your partnership and advocacy and sort of working together as we work on improving our systems too, so that people can get into the right places to optimize the needs for our community. I think even just I think we just made a little side comment here when you were saying, you freeing up those beds is good for Regions, for your thin profit margins, but it's actually what we need to do for our community too.
Yeah.
And so I think the value proposition of what that return on investment, if we all were operating in the optimal state, along the whole continuum is really key, and we need to continue to have conversations about how we do our part, and we need our partners to do theirs too. You know, I think it's kind of like what we were just saying when we met around figuring out the right roles of responsibilities where we do our share of things. And I think there's a real opportunity there. Just understanding the depth of how that impacts something like rippling through is really significant for us to understand that. So I really appreciate you talking about that.
And I think we're basically done, unless
Yeah.
we slipped in some more slides. This is exactly the
Yeah.
conversation we wanted to
Yeah.
have. See if there's, I think there's one more slide.
Yeah.
Yeah.
And one more.
Excuse me,
I
This
just
is,
wanna.
but this is what we're talking.
chime in to or ask, is if conversations have started about like prioritizing folks who are Medicaid pending, who are at the hospital to partner with the county on that?
I have not had any conversation, so I think that is something where if there is somebody, you know, in your organization that we should be talking to, maybe we need to make sure that's happening, so.
Yeah, and I think Rochelle probably is close to this, but
Mhm.
we do meet monthly, we do meet, we do. But
Mhm.
it's felt like sometimes when the patient is in the hospital, they get deprioritized because it feels like they've got a safe place.
Mm.
And I would just like to argue that still isn't the right thing to do in the context of how we use our resources. And even moving somebody up on the list so that it takes 60 days instead of 75, the
Mhm.
patient's really ready to go yesterday.
Mhm.
And so we don't need 60 more days. It's really how long does it take to get the paperwork together? And we'd be happy to partner in helping getting that paperwork together.
could I just add that the reason for this meeting
Mhm.
is because we have new leadership on both sides, right?
Mhm.
But this issue has been identified by the previous county board over a year ago, before Lynn came and before our new members. And we do have people who have started to try and address this. Because it's not just a county issue, it's also a state issue.
Mhm.
And we just lost our Commissioner of Human Services, which I won't make comments, but it's another indication of the kind of issues we've been dealing with as a county. When it comes to the medical assistance and everything else, it's not just our backlog, it's the state's also. So we are working on this. The purpose of this meeting is to get the connection points between us, so we could start addressing it together and maybe have more impact, not only with us, but with the states. We really need to start influencing the state on how we address a lot of this backlog. We have folks in nursing homes, all types of facilities, not just your hospital, who face the same issue. So I just want to bring that out, that we're trying to form partnerships across all lines here. Go ahead, I'm
I
sorry.
appreciate that, Commissioner Ortega, and just want to recognize that we know that the issue is multifaceted.
Yeah.
And there are opportunities within the hospital setting that we believe can set up the other systems and other partners when patients leave our hospital. So it's a continuum that we should all be just continuing to help solve together. So we're not here to say that the issue is only on the side of the county or the state. I think we all have opportunities.
No,
So,
and I know that,
Yeah.
but I
Yeah.
wanna leapfrog, right? If
Yeah.
I could, that's, okay. I'm sorry, I didn't mean to. Red, are you done?
Yeah, so that we just covered my last slide.
I'm sorry.
I don't think there's any more, are there, John?
No.
Okay.
I
no,
cut-
that
I
is-
cut
it's
into your
discussion.
act.
No, this is, I already said these out loud, so,
Okay.
I think this is exactly the right conversation. I mean, how do we take care of our community in good ways?
Well, another issue I wanted to, just for general discussion, is mental health.
Yeah.
And how do we connect? Where are the touch points where we could improve, make better, enhance, think out of the boxes? That's a big issue for us too.
Yeah, I'd be interested to see what Rochelle thinks, but when we were at 100 beds, we were always behind. We always had people in our ER. We have a ER psychiatric unit. We call it Pod G. You know, we always had patients staying there that we needed to get a bed for. Since we opened that last 20 beds, it feels like we're much closer to equilibrium. We almost never have patients boarding in Pod G. And so, so our ability to meet the needs of the people who need acute care hospitalization is reaching a little bit better equilibrium. We also have a same day program where people don't have to stay in the hospital and they show up every day for like 6 hours of programming. And that's a real good program for a lot of other people. We struggle a lot with pediatrics and adolescents, which I think is a big problem for the whole state. I don't know what else you'd add, Rochelle.
Yeah, I think you hit on all the right points. I think we have the right services available. Pediatrics is the next stage. And then, you know, just for awareness, as our population continues to age, we're starting to see a little more mental health need merged with acute medical care need. And those are beds that we don't necessarily have, meaning that someone who's in a mental health crisis may be in a mental health crisis at the same time that they're in a medical crisis. And our mental health department is set up to take care of people who are in mental health crisis and not merged with the medical need crisis. And so that's a different type of care that you would provide for that type of patient. Increasingly, that's what we're seeing in the hospital setting being our challenge, is finding places for patients who are experiencing both at the same time.
So can you give me a profile who this person is?
I can, yeah.
Okay.
I have a really great example of a patient who, and this is not an aging patient, but I have a patient who has multiple diagnoses, has autism, is an adult, has autism, also has bipolar disorder, also has a lot of other mental health illnesses. This patient has a group home built especially for them because they are unable to live in shared group homes. This patient has, over the years, spent hundreds of days in our hospital. And the patient recently, the patient unfortunately exhibits behaviors that are aggressive. And so will have outbursts and hit and punch and harm people. The patient is very large, strong, and unfortunately at their group home fell down the stairs and broke their back. And so that care that patient needed in a controlled space related to their mental illness, which was controlled in the group home that was built for them with the staff that was there. The staff at the group home didn't feel comfortable taking care of the patient who had a broken back at discharge, right? So we took care of the patient. It was very difficult in the hospital setting because of the aggressive behaviors. We couldn't take care of that patient in our regular med surg area, but they also weren't appropriate for the mental health area, right? Because of their acute need. This type of patient is the type of patient that we're seeing more and more of. And it adds a lot of complexity to the care. There's a lot of resources that we have to allocate for a patient like that. This patient's 6'3", really, really strong, and impulsively hits staff without knowing it. It's an impulse. So we have to have at least 2 or 3 nurses assigned to every care that we provide for the patient who, imagine, is in a back brace, right? But can move their arms and legs. And so they're still dangerous to the staff. And so this type of patient is not, unfortunately, it's not an unusual patient in our hospital, very complex.
So I'm trying to connect with the people we kind of have to deal with in terms of a crisis mode. I mean, some of the homeless exhibit a lot of what you're talking about. So I want, do you get like homeless folks that you?
We have a lot of unsheltered patients. We have a lot of patients who deal with mental illness, who exhibit aggressive behaviors. Yes, we have a lot of those patients that we see in our emergency room a lot of the time.
So they don't stay for the rest of their lives with you, right? So where do they move on to?
So Raphael, this is maybe something we can partner with the state differently on, and I realize it's nearly an impossible ask, but this is what used to be served by more state hospital beds. It was at Anoka, it was at St. Peter. And patients like this, because they technically don't need acute care, psychiatric care, because they are actually stable in their instability. They basically have an untreatable mental illness, behavior disorder, but they aren't easily housed in the community. And we had a similar conversation to this at a chief medical officer meeting where the state hospital system leader spoke to us, and she was very frank about how difficult it is for them because they're overwhelmed with jail patients. And they have almost no spaces for non-jail patients. And it's beyond the ability for us to solve this at this table. But how do we expand the opportunity for people to have a safe place to go in a secure unit that is probably state-run, because they don't need acute care hospitalization, but they need public support.
Well, I'm glad you brought that up, because I've been talking about the state hospitals for over a year, that's really the appropriate study for many of these ones. The difference, though, is when you talk, we're facing an overpopulation in our jails for the same reason that you're facing in terms of your bed space. We don't have a place to send them. They should not be in our jails. I mean, some of them are there 6, 7, 8 months when we could have sent them to a facility 6, 7 months ago. And they're still there. It could be a year. It's awfully expensive. So even when we say a jail population, we're still talking about the same
I agree.
individual.
Because it
Not
isn't
so
acute
much
care
a criminal.
psychiatry and it isn't criminal,
Yeah.
but they
Exactly.
don't exist very well in the community.
Well, and they could be that homeless person. I mean, there's a whole lot of reasons, but we're facing we're talking about the same. That's why I keep asking for the profile. We're not talking about very different people here.
There you go.
Yeah, thank you for bringing this up, and just thank you for all of this. This is the start of conversations as I'm thinking about it, because we have lots of work we can do together, and you're bringing up the lack of bed space for these acute care for our jail patients that don't necessarily need jails. And so I'm guessing you work with other medical facilities in your associations as we do with our other county associations. And I was just on Capitol Hill last week talking about we need to increase the numbers of people that we can put in our secure state facilities from 16. We need it larger than 16 because we need more beds for that. And so our association as a county is working on that. The National Association of Counties is working on that. And I'm guessing hopefully your association is working on that. But I think we do need to work on this all together and keep our voices together on this, because we just can't manage the way it is now, and we need to increase some of those sizes because we don't have employees to have more of them. I mean, we would like to, if the 16 is a magic number, we should make more, but we should have more, but there's no possibility of having more because we can't staff them. So we've been making those arguments with our federal government, with our state officials, and we just, of course, hope your voice will be with ours on all of that. And we just need to keep making these cases as a group. And I think that'll, we're all in need of this. And I wanted to ask another question about, and it's probably worked in with all of these, is we always used to hear all about how residents use the emergency room for their health care. How are we doing with that? Are we able to provide, are we able to get people signed up and so that they're not using emergency? That's another thing we're working on with our federal government, is to get Medicaid, people to sign up for Medicaid before they leave our jails and our prisons, let us sign them up for some healthcare. Let us get them set up in a healthcare model before they leave us. And we're asking for funding for that. They don't disagree, but they don't have the funding for it. But anyway, we know we want to set them up so they don't keep using emergency room for their basic health care. Just curious how that's going, because I know that always used to be a really, really big issue. And like I said, it might be woven into here, but it's something I think we all, want to do something about as well.
I wish I knew who the best person was to answer.
Yeah,
It's a huge issue.
Yeah.
I would say it's not overwhelmingly huge.
Hmm.
If I had to guess, I'd say 20% of the patients in our ER at any given time are people that definitely could have been intercepted somewhere else in the healthcare continuum.
Mm.
And we do have to get better at knowing exactly who those people are and how to get them to the right clinics. We have, in our system, we have a 24 to 48-hour open system. So if people know how to access it, we can get them in. The other thing, we're partnering with the federally qualified health centers, FQHCs, like the Minnesota Community Care and the Open Cities in the Riverland, which used to be United Family Medicine.
Okay.
But they need help too.
Mhm.
And because we did a little bit of we had a meeting talking about street medicine. Can we bring an ER type in tent to a community where people can get the care on their street or on their block? But then it struck us that these FQHCs are there too. We don't need a tent on the block if the FQHC is down the street. So how do we get people to the FQHC in a way that is dependable? I don't know what else you want to add.
I think I would just add from a kind of a subjective perspective is that we teach people how to use healthcare, right? And so if your normal teaching growing up was when you feel sick, you go to the emergency department, that's what people will continue to do. And so I think there's some education that we can continue to do for communities around what is the best place for you to get healthcare, and keep giving that education to people as they use the resources. I think that's a healthcare equity opportunity that we have. And we have to make it easier and more accessible for people to do that. And Dr. Hockey has made a really good point that we are starting to open up more appointments that are easily accessible for patients. But sometimes it's just the patient doesn't even know which number to call, so they don't feel good, and so they go to where they know that they can get care. And so I think that's a part of it, but I know John has probably some good comments.
No, I just know that we've historically partnered with the FQHCs, and we've actually shared the cost of individuals who are been staffed in our emergency rooms. And so those individuals shared in the redirection back to that, identifying actual patients that, you know, this type of care could have been done in a federally qualified healthcare setting. Here's our facilities, here's when we're open. There's education in the community, but I also think there's, and I guess I'm sensitive when I see patients where it's like, and they're coming in at 8 o'clock at night, it's like, where else do they go? Where else do they go if there's not an urgent care?
Right.
Every one of us gets in our car and we go drive to another place. But they cannot. They're on the light rail, they're taking an Uber, they have nowhere else to go though. And so where else do they go? And so when we talk about these healthcare settings, to me, it's gonna be, how do we expand times of service? How do we, so I think people want to hear both. They want to hear there's a place to go, but there's also an expansion of service times, and when can they go there?
And are there virtual options? And are there other, options that people have?
Excuse me, Commissioner Moran and then Miller.
So some of the things that we've been talking about in regards to emergency services, having healthcare coverage, we're hearing that there's a fentanyl crisis and people are showing up at Region Hospital in the emergency room. They're dealing with mental health, and where do they go? We talked about state hospital, and some people still see state hospital through that institutionalized model of that care. And I think we're smarter, we do things different now. And so as we think legislatively about how we do that, I think it will be, just think about, as we talk about partnerships, what that would look like with a partnership, just helping and educating legislators on this new 21st century type of institutionalized, where people are getting the services they're needing, they're being taken care of, because there's a lot of pushback around that type of conversation and narrative. I just want to thank you for the work that you do with your trauma center, looking at your heart center, the work that you do around that. It was really good to hear the work that you're doing around Black maternal health. That was definitely going to be something that I talked about, but you guys are working and leading that in that way. looking at the, Black maternal mortality rate. But we see that you're working to, I think you said the postpartum deaths are down 18%. Because usually that's what happens, because often like women are saying their pain is not being heard. People are not paying attention to that. But also, maternal morbidity is another issue, because we don't get the death, but a lot of those near deaths are happening. But the work that you're doing around that seems to be leading us in a good direction. I really would like to see how we can partner around the mental health police within mental health placement. Those numbers are growing. They're absolutely growing, and we need more beds. I'm glad you have 20 more beds and 120 beds. But the need for it is still outweighing access and being able to have that type of coverage. So thinking about, we have judges that saying we can't send another person to prison, right? Jails are not where they need to be. They need to get the help that they need. And so finding what that looks like or what that could be and how can we supply that, whether it's region, Bethesda, someplace, somewhere. What do that look like and what part do we all play in delivering the services that I clearly hear are the values that you carry. And I just want to say your values are very strong. I am really impressed with the values that Regions is carrying and really the opportunities and the processes that we have in place.
Thank you. So I just have a couple things to add. So the healthcare coverage, I know you noted before that a lot of times it's waiting for people to, waiting on their insurance to kick in. How can we be proactive about that in the beginning? So people are not coming to the emergency room because they're in tremendous pain and they're not utilizing urgent cares or doctor's appointments because they don't have coverage. And then they're admitted and kind of essentially not stuck, but like you said, ready for discharge after day 5, but within our facility, with your facility for an additional 30 times waiting. So is that just, again, an education piece? Is that I know the state is also addressing some of this as well with some funding opportunities available for health institutions, nonprofits, and also local cities and governments on how to get, so there is no lapse in coverage. And I also want to echo what Commissioner Moran said about your values, and how you are willing to help with or without coverage. I personally have an experience there with my father, and unfortunately he passed away within 2 weeks, but was able to come to Regions and receive the care that he needed, that he was denied at another health institution in a different part of our state. So Regions definitely has a soft spot in my heart because of that, and it's where I gave birth to my son. So it's a great facility for that. So I just, want to kind of also echo, like, what can we do as a county to help out on our end? And if you have some suggestions, we're opening, or at least I'm open to hearing about them. I'm being proactive, so we're not always so reactive, right? And if some of this stuff is, like Commissioner Ortega had said earlier, that they're aware of some of the backlog that we have already going on prior to us coming here, and we have some great new leaders in place that are addressing that, but how can we continue to do our part?
So I have to say, I'm so impressed with this the commission, that's what it's called. I just.
The board.
Board, but because I mean, you listen to what's going on at the state today, and this feels a lot more functional. So I really value that, but it strikes me that, we'd be happy to set up a group with you if you're the right forum to figure out what to do with what I'm gonna define as chronically mentally ill, because I think we have the capacity for the acute decompensation or someone who's having a bad experience, but I think we're talking about a group of people that are static, that additional treatment doesn't help them, and they don't need hospitalization, but they need something different than what they're getting today. I'll also say that it would be great, and I think Bahu is maybe the right contact person, but the public health community outreach, how do we make paperwork easier? Because anything, I mean, I find paperwork to be super confusing. I can't imagine what it's like if
individual.
if you don't have my capacity to try to get through it. So how do we approach people where they're at and help them get what they need?
I was just thinking about, like, none of this is easy. We're talking about, MA pending, like, it's just, oh, we just need
Yeah.
to do this paperwork and
Yeah.
it should be done. None of this is easier. We wouldn't be
Wouldn't
having
be
this
doing it, right.
discussion. Every hospital wouldn't be facing the same struggles. I'm really, this is obviously my first time meeting most of you and really hopeful. This has been a great conversation, exactly the things we wanted to talk about. And I think a separate work group to dig into what exactly can we do, some tactical things that we can do. And I think there's some people at the hospital that we should bring to the table that would have some really good insights that do this every day and have tons of ideas, and some of them it's like, oh, we've tried that, it didn't work, and maybe we have a new opportunity to open some of those ideas, both for the paperwork side, the mental health side, and all the things we talked about today. I think that would be a really good next step.
Commissioner Sean?
Thank you. Thank you for being here and for presenting. I'm just very hopeful that, there's a lot of like shared values and where we want to go and serve our residents. I would say, I've been on the Emergency Services Board, the Metro Emergency Services Board, and that's where the Metro, EMS dispatch centers are here. And I would say majority of the calls for police for 911 is for health related issues still. And one of the top ones are around cardiac arrests and of course opioids. And we have this, we have the 555 mobile clinic. We have a mobile clinic here from public health as well to just screen. But I would say, I think we also need to take a look at a more like a precise look at about like where the most common prevention is. And I think you're already doing that around like strokes, signs of stroke, signs around heart attacks, and when to get help and call. And then also layered in with just more culturally specific in communities that you see where it's more common and prevalent. And so I would say like getting help and support from you all with like getting disaggregated data would be really helpful. Trying to partner with public health to move up the chain, right? About like going to prevention versus like just treating it on the back end here would be great. And I see our public health team here too. So thank you for being here today.
I'll just follow up that comment with a call out to the public health team. And many of you have worked with, and I'm looking at Dr. O'Dowd and like a lot of the programs that we've worked with, and just appreciate that team is hardworking and we all want to do what's best. And so just want to give a thank you especially to all of you.
Commissioner Jevons Singh?
Yes, well, first of all, I just want to echo what you were just saying about the level of the discussion here and the nuance. Many of the things that I had thought to bring forward have already come up through the natural deep conversation that's here. So I just thank everybody around this table for taking it to that level. One of the questions that I had is we kind of glossed over in our discussion around adult mental health, the gaps in future growth in pediatric and youth mental health. And I'm just wondering if we could get a little bit of an update on where you feel you are now and where you'd like to get to.
Well, we're a level 1 pediatric trauma center, but we don't offer any pediatric mental health services at this time because the adult mental health services, I think, were a priority as we were growing the program. But I think what we're increasingly seeing in the Twin Cities is that need. So it's, it's an obvious need that we have, and definitely a priority that we're looking into, but I don't know, what else would you all?
Well, it requires a critical mass, right? Because Gillette is a pediatric hospital, Regents is not a pediatric hospital. And so in order for us to be able to do pediatric psychiatry or psychology, it would require beyond compare investment. It would just be a new business model completely, which leads me to the fact that we need to depend on the people that are doing pediatrics now in the city, and recognizing that I think what I'm gonna say is gonna be relatively ignorant. It feels like a lot of the pediatric psychiatry work has been in the for-profit sector. Some of those hospitals are for-profit, which argues that the not-for-profit sector must not be able to make a go of it. And I think it would behoove us to figure out why that is and what the gaps are and what the barriers are. I think that Hennepin did pediatrics. I think Fairview does pediatrics. Not sure if Alina does. Children's does. And so I think we should, it would behoove us to find out what their barriers are and to help them expand. Because I know when we're looking for a pediatric bed, I mean, we had a gentleman, a 16-year-old in our hospital for 21 days. There wasn't a single bed for pediatrics anywhere in the state.
I think this is also a product of there being an extreme rise in the need for adolescent mental health, or at least our recognition of it. But I wonder if Puhu and I sit on a roundtable, East Metro roundtable, that's chaired by the mayor and the president of Health Partners, Andrea Walsh, and it might be a discussion that we could have.
We could, and I just want to note Sophia Thompson,
Yes.
often attends, and she's amazing, and we're glad to have her as part of that East Metro Mental Health Roundtable. And in fact, at that last meeting in November, we gave a brief presentation on Health Partners Rapid Access Mental Health Service, where we have a mental health provider sitting alongside in a clinic with primary care. So individuals who come in, perhaps that primary care doctor realizes that this person might need some mental health attention. Down the hall, they get that patient's permission, walk down the hall to meet with that mental health professional. Have that conversation same day, often within 24, 48 hours, get seen. And in it started as a pilot, and in our 2-year, we learned that only 15% need further services treatment. They just need to see someone right now. And I think anybody who's gone through, picked up the phone, wanted to make an appointment, you have to wait 4 to 6 weeks at least. So by the time that happens, this person is already struggling. And so that's why they sometimes end up in the emergency room, because they have something that's more catastrophic than what they needed in the beginning. So perhaps at a future meeting, we can come back and talk about that specific program that we did highlight at that last East Metro Mental Health Roundtable. It is in most of our clinics now, this model, so that we save the beds for those acute cases. Because I think all of us who've been around this work and who may have been at the legislature, you can't build beds fast enough. Like, you can't build your bed out of this. I think it takes both providing the best service that we can within our facilities and looking upstream as to the root causes. And some of those have to do with unsheltered, not having homes, not having access to livable paying job, not having access to food. And so that's why the partnership, although I went over it really quickly, which is why we make investments there. Because we already know that even within our employee population, we know we have folks who work for us who are food insecure. So it's not someone else, it's actually everybody in our community, people who work for us, people we know. It's someone you know who is going through these crises quietly that lead them to need these services that we provide. And so it takes this, I always think about Sue Abdul when she says, we don't have a mental health system. We have a fragmented one that we just kind of put together. So it's not the way we would design it today if we were going to design one, but it's the one that we have, and how do we improve upon it? And so I think as we sort of wrap up here, I think what certainly we'd like to see is, and working in partnership with all of you, commissioners and the amazing staff here at the county, how do we come up with a process for escalating cases? Some cases will just need to go through its natural course. We're waiting for paperwork to get done, and we've done all that we can to ensure that that paperwork has what it needs. But there are some cases where patients are sitting in our facilities 120 days that really do need escalation. And when that happens, what does that look like? How do we all not be surprised when that moment comes? So I think having a process for escalating, I'm hoping, smaller patient cases where we're saying by the time we call you about these cases, they're really at an important and urgent stage.
Mhm.
And that means that not everything can be important, and urgent either. We have to discern that on our side, but by the time we pick up the phone and call who here at the county, that we know, okay, we've set up a process, we've tested it, it works, and this is the process that we're gonna join together to help solve for this situation.
A quick point of clarification, with the number of folks who are overstaying their need in the hospital, which percentage of them is it because it's held up on the MA and which, because it could be other things. It could be
It
that
could be
there
other
isn't a place for them to go. It's like, what percentage of your population do you think it is this particular issue compared to other, like, stream of
10%.
care?
10%.
Like 10%.
Yeah, because
Because I don't want us to forget that part of this problem
Yes.
too.
we have 50 patients on any given day that are in the hospital over 30 days. Half of them have no acute care medical needs. 3 to 5 of them are waiting for
Okay.
MA.
And that's easy to catch
pending.
easy.
So 3 to 5 of the 25, so 20%.
You know, I want to wrap up because I know other commissioners have appointments. I want to wrap up what we have, and this is a great discussion. So we've identified the issues. I want to mental health. How do we're gonna explore psychological services for the younger
Yeah.
population. For the chronically ill, advocating together at the state level for facilities, for more beds in state facilities. The medical assistance issue that you were just talking about. Our contact person should be Ling. Because we really want to, on this side of the aisle here, we want to really make progress on this. We're gonna need, some of these topics need more research, some need more time by our expert staff, and oh, Sophia left, huh? She was hiding behind you, I didn't notice, so I would have called her up, she does a much better job than I do. And so those are the 3-4 issues that I've identified that we're gonna work on. And if there's agreement on that, we need to set up contact. Ling is our contact person, so we set up those, whatever we need, the work groups.
Yeah, Mr. Chair, I was just gonna say, I think from our perspective, I'd like to solidify
Yeah,
more of
I
a
have that.
partnership roadmap of sorts. And because I know there's a lot of staff from different levels doing work, I see even our government relations, there's a lot of intersections, so let's get clarity on that,
Right,
yeah.
exactly, My Chung just told me the partnership with public health. I mean, we intersect in so many places with our department. It's not just one department. I make the mistake of asking Sophia to answer every question, and she wisely tells me, that's really not my area. You need to call so. So for us, we need to make all those connections with your folks, so we get the right answers, right? So I think we're moving forward, and then to your point, and maybe you could be we need to meet again down the road, 6, 7, 8 months.
Mr. Chair, good thing Ling and I already know each other.
Yeah.
so-
Yeah.
6, 7,
Yes.
8 months, and how are we doing? And where have we been making progress?
Yeah, the last thing I wanted to just mention is I think we need to pull your community assessment as part of some of the work that our board uses as baseline information. I know we have some community organizations that have done some community assessments too, and I don't think the county needs to reassess the community. We have a lot of organizations that have looked deep in lots of crevices of the need, and so we'll pull that in for the board as we do our 2025 year planning as well, so. But thank you for being here.
Hold on.
Just before we end, just one thing I did not mention is your birth center. So it is high quality, very inviting, very supportive. I've had 2 grandbabies that have been born in the birth center that I spent more time and more hours there helping to deliver babies or videotaping it all.
Yeah, right.
But it's a great space, so I just wanted to just say that.
Yeah, good. Thank you.
All right, well, thank you
Thanks,
very
everybody.
much for taking
Thank
us.
you.
through.
We can start with 5 people.
Thank you.